And good saying is a charity. So this is our principle from our Prophet Muhammad sallallahu alayhi wa alihi wasallam. And this is correct everywhere. I lived in the UK for 13 years and I can see the principle of our Prophet there, but it is not under his name. You know, Bernard Shaw, it is a great saying, progress in life is impossible without change, and if you can't change, then you can't progress, so there must be a change. MGB, as you know, is introduced by Rutledge, 1997. He is a trauma surgeon. When he introduced the procedure to American Society of Metabolic and Bariatric Surgery, they rejected his procedure because they are all big names in the field and he's a trauma surgeon. Who are you to introduce a new procedure in this country? They teased him in the meeting when he presented his first series of 2,000 patients. And they are still in a battle between them, actually. Rutledge, who invented this procedure, he has not been invited to any of International Federation of Obesity meeting because of this political and fight for power. Even the last meeting in London, he has not been invited. The training courses they held for MGB in London, Rutledge is not there. People coming from everywhere to train people and to explain the tricks of MGB, but the person who is living among us is not being invited. It is not Mason technique, because as you can see, Mason is connected the bowel to the splenic side of the fundus. And that has resulted in severe bile reflux. That's why the operations abandoned. And no one has done it, although there was initial success of record of weight loss for obese patients who had peptic ulcer disease. For this group of patients, Mason has introduced this procedure. Mason is a still living person. I think he's 86, 87 years old, and replying to his emails about his previous operation. Very kind man. This story, why Rutledge MGB rejected in America, is reminding us about Eric Moyher when he introduced laparoscopic cholecystectomy in 1985. And he presented it to the German Society of Surgery, and they teased him, and they called him Mickey Mouse surgery, or a small brain, small surgeon. And then when he has done one of the patients who died in 1987, they prosecuted him. And then the procedure introduced in the United States, accepted as a new change in modern surgery, then the German society recognized his work and they apologized to him for the way they treated him, actually. He died in 2005, Eric Moyher. Then this is a new name in MGB surgery, Carbajo, Miguel Carbajo. He learned the technique, and what he has done, he just did what we call it anti-reflux surgery, because one of the concern of MGB is the reflux, bile reflux. So he is suturing the posterior side of the stomach 8 to 10 centimeters above the side-to-side anastomosis. This is what he has done. And he gave it a new name, one anastomosis gastric bypass. But essentially, it is the same procedure, Rutledge technique. And if you go and study the largest series of MGB, the bile reflux is very small, whether you use Carbajo technique or Rutledge technique. So what is the difference? Why there's a new name? It is, again, is a fight for power. Everybody wants to present himself as a big name in the technique. So why I have change? I have desire to change. I just when you do a procedure and there is a problem with the procedure, so you seek for improvement, you seek improvement, so you have this internal desire to change. Steve Jobs, you know Steve Jobs' story. He's Apple chief executive, and when he started the company, Apple company, he went to the chief executive of Pepsi Cola, John Scully, and when he met him, he asked him a specific question: do you want to join me in this new company to change the world, or to stay, you just sell sugared water, Pepsi Cola? So that has caused huge impact in John Scully, and he joined him as a manager for Apple company. So what are my specific reasons to change are the following. We don't have, as a bariatric surgeons, metabolic surgeons, we don't have ideal operation, perfect operation in the field. Our tools are dangerous, and you heard yesterday there are horrendous complications, and patients, young patients coming for elective surgery, and they die after a week or two because of our complications, because of our bad decisions about our patients. We don't understand our patients. We don't have the infrastructure to put our patient safety as higher standard as it should be. We found our tools cumbersome. It's long learning curve. For Roux-en-Y gastric bypass, you would need to do 500 cases to cut your operative time short. You need 500 cases to reduce your complications. So it's a very long learning curve. MGB recorded research and data has shown superiority to the current bariatric surgery outcomes or data. MGB advantages is reversible and revisable operations. It can be adjusted to the needs of the patients according to the comorbidities and BMI. You can just adjust the biliopancreatic limb. So it gives you more flexibility to adjust the procedure. I personally don't have conflict of interest with my private practice or my connections with other companies to limit me from introduce this procedure to my patients. I have the desire and the ability to change. I have flexibility to change. And more importantly, MGB has been approved by British Obesity and Metabolic Surgery. This is one of the important limiting step. So the experience I'm going to present is talk about it is experience of 2 units in South London and in Doncaster. And I wanted the experience to start the procedure in my hospital just like this little boy. It is dangerous ride, and you have to be quick, flexible, intelligent, and you know how to steer your big teams and big people in your department and in your hospital. I didn't want it like this one, because if I start a new procedure and I have the first patients or second, third patients severe complications and they died, then I am in big trouble. So we don't have perfect operations. From our previous experience of 2,200 Roux-en-Y gastric bypass patients with 75 to 150 centimeter biliopancreatic limbs and 100 to 150 centimeter alimentary limb, we have complications, dumping syndromes, internal hernias. We have 2 mortalities. 1 patient died after a year from operations because of encephalopathy in another hospital. The second patient died within 6 weeks of operation because of acute renal failure, long procedure. He was on the table for 4 hours, and he's 250 kilos, and he developed acute tubular necrosis, and he died in ITU. We have 6% revision rate after Roux-en-Y gastric bypass, and we have 15% excess weight loss failure, and 15% weight regain after few years of operation. We have done about 1,700 adjustable gastric bands. A new research in the field has shown there's one of the largest study, 52,000 patients. From United States, it showed 6% annual removal rate, and more than 60% of patients, they needed revisional surgery. So why we are doing adjustable gastric band then? If we examine academic centers in the United States, in 2015 they have done 28,000 adjustable gastric band. In the same period, 12,000 patients underwent removal. So why we are doing it? Even in academic institutions, these institutions you expect they apply science to clinical practice, still there is a problem in the United States. If we come to sleeve, up to 1/3 of sleeve patients will fail at the 5th year and half fail in the 7th year. Excess weight loss is better with BMI less than 35. Even Professor Michel Gagne's study, who is the godfather of sleeve surgery in the world, his recent studies published in Surgical Obesity and Related Disease 2017, he found that 31% of his patients reported gastroesophageal reflux at 8 years. And as a surgeon, upper GI surgeons, we know that reflux disease is linked to Barrett's esophagus and lower esophageal cancer, which is one of the commonest cancer in the Western country. Then why we are still doing a sleeve for our patient? The most recent study, systematic review, which is very powerful, study in obesity surgery, 2016, it showed the sleeve patients, 75.6%, they start weight regain for different reasons at 6 years. Its Cochrane study showed reoperation rate, it could reach 24% in Roux-en-Y gastric bypass and 34% in sleeve patients. So it's basically we don't have perfect or ideal operations. I showed you this slide yesterday. This is the most powerful study, and I think it has been referenced in 1,600 studies in the world, source study. It showed, although we can achieve short-term success, but we can't maintain it for a long period of time. And after 15 years, diabetes remission, type 2 diabetes, is only 30%. So it's still not ideal. We don't want this. Even excess weight loss is only 25% after Roux-en-Y gastric bypass. It's not perfect. So we found our tools are dangerous. Sleeve, gastric bands. We operated on horrendous complications of adjustable gastric band, sleeve, and Roux-en-Y gastric bypass. The mortality rate of revisions can reach 0.6%, which is high. So we have to look for a new low-risk operation, a forgiving operation. If you study Roux-en-Y gastric bypass, it has been considered as gold standard operation bariatric surgery. It is not gold standard operation anymore. Even Kelvin Heger, the godfather of Roux-en-Y gastric bypass, admitted it on Baum's meeting 2 years ago, and he said it is not a gold standard procedure anymore because of a problem we have with this procedure. If the patients develop liver failure after Roux-en-Y gastric bypass, mortality 60%. Protein malnutrition after Roux-en-Y gastric bypass could reach 4.7%. If we come and examine our UK data, mortality 0.17%, revision rate 6.3%, 65% will achieve resolution of diabetes at 2 years, but you expect this to be half in about 10 years. So it is not perfect. And excess weight loss is about 60% at 3 years. So we need a change, because if you do the same thing, you don't expect different results. The other reason why I have changed, because of perioperative risk. On the learning curve, you need, as I said, 500 cases for learning curve. So 500 cases of Roux-en-Y gastric bypass for quite long learning curve. Operative time, studies have shown your operative time will stabilize. You cut it. When we started, we've been doing Roux-en-Y gastric bypass in 3.5 hours, but we cut it to 90 minutes. But some surgeons, they can do it in 45 minutes, but you have to cut corner and you take 1 in 10 patients to theater again. We don't want this. Cost effectiveness. If you have leak from sleeve, is a big problem. It's long intensive care unit admissions. Patients could die from leak, actually. Additional outpatients cost for investigations, outpatients clinic, admission, diagnostic laparoscopy. So the bill will be very, very big when you have complications. Most importantly, studies have shown the post-operative readmission rate after MGB is much less than sleeve and Roux-en-Y gastric bypass patients. You can cut readmission by 11% overall rate. But interestingly, the readmission rate after Roux-en-Y gastric bypass has been doubled after 3 years of operation for different reasons, for complications after the procedure. If we compare our MGB to Roux-en-Y gastric bypass or sleeve, then there are other costs could be saved. So there will be no revisional surgery for candy-cane syndrome. Candy-cane syndrome is a blind loop, long blind loop, 10-15 centimeters. That is a cause of chronic left-sided upper quadrant pain. You investigate these patients after Roux-en-Y gastric bypass. By CT scan, gastroscopy, you can't find anything. Take them to the laparoscopy, you find very long blind limb. And before that, if you have facilities, you do bacterial overgrowth test, and that's positive. Then you go and resect this. Very easy operation. You can do it in 20 minutes just to resect this segment of the bowel, and the symptoms will improve. After MGB, I think there is only one case of internal hernia after MGB reported in literature, while in gastric bypass, I myself operated on 5 patients from different hospitals last year because of internal hernia following Roux-en-Y gastric bypass from 1 year to 10 years after the operation. If you do MGB, then you avoid JJ problems. I myself have severe complication with one of my patients, JJ problems. He was in ITU for a long period of time with multiple organ failure. If I have done MGB on that patient, I could save these complications and long stay in the ITU. Provisional surgery for chronic abdominal pain. I think everybody has this experience. You do Roux-en-Y gastric bypass, and patients after 6 months, chronic left upper quadrant pain. Possible Professor Bazuki will tell us about it. You investigate. You start with gastroscopy, normal anatomy inside, Roux-en-Y small pouch, no stomal ulceration, short blind loop, normal rule limb. Then why he has left upper quadrant pain? You do a CT scan. There is no evidence of internal hernia, no evidence of new pathology. There is no retroperitoneal tumors or anything. Why he has then left upper quadrant pain? You bring them for laparoscopy and you can't see anything in the laparoscopy. Some surgeons, they are just discharging patients to their GPs, give them painkillers, refer them to the pain team. Is really big a problem after Roux-en-Y gastric bypass. The other possibility of chronic left-sided abdominal pain is JJ anastomosis is a problem, whether it is narrowed, whether there is ulceration on that area. So it is a reason for investigation and cost. Also, the revisional surgery for failure of the procedure. If you do a procedure and associated with high rate of failure, then the cost of revisional surgery is high. The new emerging research of MGB, or one anastomosis gastric bypass, has shown the results are better at short term, but honestly we don't know whether we can maintain these results on long term or not. So we are not biased. We know it is a bariatric operations, it's associated with failure, it is still not a perfect surgery. But the yearly short term outcome is much, much better than current sleeve and Roux-en-Y gastric bypass. As you can see, diabetic remission is about 90% in the first 2 years after MGB, and excess weight loss is 74.9% 2 years after MGB. Mortality 0.14%, slightly better than our UK mortality rate. And this is a study of 7,000 MGB patients. More importantly, Kwan et al. Did a meta-analysis, and he found that excess weight loss, diabetes remission, operative time are much, much better with MGB compared to Roux-en-Y gastric bypass and the sleeve gastrectomy. One anastomosis and MGB can give you more flexibility of reversibility, as Professor Bazuki showed us yesterday in the video. You just dismantle the anastomosis, do JJ anastomosis, stable, you close the enterotomy. It's 45 minutes operation, maybe less than this, experienced hands. Revisability. So you do MGB with a 3 meters biliopancreatic limb, patients develop liver failure or malnutrition or excess, more than 100% excess weight loss. You just shorten the limb, dismantle the limb above the gastrojejunectomy, and you create a new junction. Easy. There is ethical issues. As surgeons, we obliged to produce the best operation or intervention for our patients. It is a crime, we consider it a crime if we know that the operation we are going to do to our patient is not the best one, and there's another alternative which is better and we don't do it. It is a crime. And I don't have conflict of interest with when it comes to business or money or private work. I'm going to talk about two concerns after MGB. So bile reflux and upper GI cancer. This is the big ho-ha against MGB in the UK and in the United States. If you come to MGB studies, thousands of patients, Kohler, Lee, Rutledge, and Sheffield. The incidence of bile reflux after one anastomosis gastric bypass is 0.1 to 0.7%. We are not talking about 10 patients or 50 patients, these are thousands of patients. But to be not biased, we have to explore Roux-en-Y gastric bypass as well. 36% of patients of Roux-en-Y gastric bypass showed reflux in the remaining stomach and biliary gastritis. Improvement score is 56% of Roux-en-Y gastric bypass with hiatal hernia repair. The other concern is upper GI cancer following MGB, because Mason has connected the bowel very close to the gastroesophageal junction and caused bile reflux. Still this imprinted in the brain of surgeons. They don't want to change. They consider MGB is Mason's old version. It is not. It's a completely different procedure. So after 16 weeks of follow-up, there's a pilot study done in Paris on rats, animal model. It didn't show any evidence of changes in the lower esophagus after 16 weeks of follow-up. And the author concluded that it's unlikely to be a long-term effect on the lower esophagus to cause cancer because of biliary esophagitis. How many gastric cancers reported after MGB? There's only one case. And it is not at gastroesophageal junction, it is not at the pouch, it is in the remaining part of the stomach. We know from our previous studies that if you do Billroth 2 reconstruction after gastrectomy for peptic ulcer disease, they have the same incidence. They still can develop cancer in the remaining part or in the proximal stomach. So why you go to these meetings and the criticism is to MGB, it is associated with cancer. If you take your colleague aside and discuss the operations with them, they raise these concerns. I just don't understand why. There's no scientific basis to support it. But then if you go to New England Journal of Medicine, impact factor 40, one of the strongest journal. If you get one article published in that journal, you are a king. 338 patients managed by Billroth 2, 25 years follow-up. Only 2 cancers detected compared to 2.6 expected cancer in general population. So Billroth 2 reconstruction is nearly similar. It is not exactly the same, but similar to MGB reconstruction. Still, the cancer rate after 25 years of follow-up is much less than normal population. Then why you expect MGB is a cause of cancer in future, 20 or 25 years? And in the UK, bones, big people in bones, British obesity metabolic surgery, they recommend that MGB is not for young patients. It is for old patients, because the reason we don't know the long-term follow-up of these patients, but we have the scientific evidence after 25 years, the risk is much less than the normal population. I don't understand why. Going to British Journal of Surgery, impact factor 6, one of the best journal in Europe, and the study risk of gastric cancer after Billroth 2 resection for a duodenal ulcer. And again, this study is very long, 10 follow-up, is about 22 to 30 years follow-up. They concluded that individual who subjected to Billroth 2 resection of duodenal hardly have any higher risk of carcinoma than general population. Is again big study, long-term follow-up. It didn't conclude that if you do this type of reconstruction result in cancer. The only thing I understand why other people against MGB is because of ignorance. I can't have any reason, I can't explain it. So the big question to us, is there any ideal bariatric operation? In my opinion, no. Is MGB an ideal bariatric operation? I don't think so. Because still we have a problem with MGB. We have a problem of bleeding, obstruction, wrongly done MGB, it can cause really big trouble. We have a problem of leak. We have a problem of unexpected weight, excess weight loss. We have, I think, 2 patients, they lost about 120% of their excess weight loss because we've been very aggressive with them with biliopancreatic limb. And I showed you yesterday we have 2 patients with liver failure because of long biliopancreatic limb. And some patients, they have protein malnutrition as well. So, as you remember, Halstead has done his radical mastectomy. It was gold standard breast operation. Now, looking back to Halstead operation, it's mutilating, it's aggressive operation. And now we are moving towards lumpectomy and very, very conservative breast cancer surgery. Even Nissen, he did his Nissen fundoplication operation, started in 1950. And himself, he operated on Albert Einstein. From our studies on our patients of anti-reflux surgery, they come back with failure. 10% will fail in 5 years, and possibly 20% or 30% will fail in 20 years. So this is not ideal operation. Any questions? Thank you very much.
Thank you very much, sir, for this very interesting talk. In fact, it was not just a talk, it was a very long experience of this very, very important modality of morbid obesity surgery. Now the floor is open for questions, and if any question for Dr. الزهرة Sharifi. It's 10 minutes only for questions. Yes, please. Yes, yes.
Okay, thank you, Doctor, for your nice presentation. I just want to ask if nowadays there is a new bariatric surgery, a single loop ileal anastomosis plus sleep gastrectomy. Is there any comparative study with the MPG?
I'm not aware. I think Dr. Ali raised the question yesterday. I'm not aware of any new studies comparing both procedure. But I expect, in my experience, the new one, if you resect the residual stomach, you are going to remove a ghrelin hormone secreting area. That's important features in the final outcome of bariatric surgery. So possibly, in my experience, I think that will improve the results, definitely. But I think we shouldn't take it lightly like this. If you resect the remaining part of the stomach, you have to prepare yourself for complications. And one of these complications is splenic injury, splenectomy. You are going to dissect on the right side of the abdomen, so sometimes the colon splenic flexure on this side, so I'm not sure, but I mean in experienced hands, you expect these complications are less and less. I mean, how many cases we have colonic injury in our series? Only one patient from Roux-en-Y gastric bypass series, but we recognize it during the operation. You just put a stitch. Sometimes there's burn on the colon, but coming to the spleen is better to avoid. As a bariatric surgeon, it's better to avoid spleen if you can. But if the studies, if it just begin now, we need a long-term data. We need large number of patients to judge whether this really we need to do it. Because if the short-term and long-term data showed that improvement in excess weight loss or type 2 diabetes by 1 or 2%, I don't think it's worth doing it. But if it shows significant improvement, statistically significant improvement, then yes. The answer is yes. Yeah.
Yes. Thank you, Mr. Chairman. Thank you, Dr. About the reweight gain, about the sleeve gastrectomy.
Yes.
65% reweight gain is very much percent. In our locality, in last searching population, last year in 2016, our locality, the reweight gain between 10 to 15%. 65 to 70% is too much.
It's too much. The problem is...
Our patients also they are present and for
Yes. I must admit I may be biased in that to present this study, but I presented it to show our failure as a bariatric team. I'm not speaking about myself. So I'm speaking about the bariatric society in general. The problem is we are surgeons and we always want to report our best results and we try to hide our worst results. This is in our blood and human nature, as you know. So, come to your question, the short-term data, you possibly have a follow-up of 1 or 2 years or 3 years. But if you go and study sleeve data of long-term, even Gagne's study himself, it showed 31% of reflux after a sleeve gastrectomy. From our experience, we have done 500 sleeve gastrectomy patients, and I think we operated on 20% of these patients again because of failure to lose weight or to regain weight. So sleeve, they will fail, and not, I said, all of them. To be successful with the sleeve patients, as with any other bariatric procedure, you need to have intelligent patients to help you as well. You do the sleeve, and these patients, they go and eat. They expand their sleeve in 2 or 3 years, and they come back with weight regain. They will lose it in 5 months, 6 months, first year, and then they will come after 2 or 3 years with weight regain. So it is a problem actually, and that's one of the hot subject in sleeve gastrectomy surgery. If you go to these meetings, sleeve meetings or discussion sleeve sessions and IFSO meetings, what are you going to do with them? Are you going to re-sleeve them on very narrow, to make a very narrow tube? Or are you going to change them into Roux-en-Y gastric bypass? Or are you going to change them in mini gastric bypass? Or are you going to add a band on them? Or are you going to change it to SADI procedure? So it is a debate, it is a hot area, but the message I want to transfer to you, dear colleagues and the brothers in this hall, is we are not perfect and we don't have perfect surgery. But we are obliged by our profession, by dedication to our patients, to produce the best possible procedure to understand how these procedures working so we can tailor it to specific clinical scenario, and we have to understand our patients. It is a big operation, it is a teamwork, it is not single person field. And the most importantly, I feel always when I have complication I consult my colleague. It is not a shame to consult your colleague because you are behaving in best patient's interest. So sometimes you say, well, I am the best surgeon in the hospital, I don't consult Mr. A or Mr. B. In my opinion, it is not right. In every complications myself, I pick up the phone and I ask my other 3 colleagues, I have this patient, I have this complications, I'm going to do such and such, what do you think? 3 brains, 4 brains is definitely better than 1 brain. And in most of the cases you are covered. Even, working in the UK, you are covered. I seek the advice from my colleague, I've done this approach. This is the perfect thing to do. So I advise you here, if any one of you have complication, just pick up the phone and ask your colleague. It's not a shame at all.
Yes. Thank you very much. The last question,
Thank you very much, Dr. Zara. Nice presentation and nice talk. We know the new idea about all morbid obesity surgery is not restrictive or malabsorptive surgery. It is a change in the hormone of the body, not affecting the patient only, also the sampling of the patient. And this is a study made in many countries. My question, you prepare MG, many or single loop anastomosis rather than sleep, but many meta-analysis in the world support these or that. So still now, we not agree as a surgeon on single procedure in the world. Some yes, I agree, there is the recurrence rate or gaining weight of sleep high. But nowadays, there is no correction by surgery. There is addition of drugs, medication for sleep, which help the surgeon and the nutritional support. As you know, and you said also, it is a teamwork, not surgeon only. Nutrition support us, and must support us. In Iraq, we lost this, actually. So we don't know till now which procedure is best for our patient, unless it is that the patient is diabetes, we know that the bypass more effective than sleep. Thank you very much.
Yes, that's absolutely correct. Thank you very much for your very, very scientific comments. There are lots of debates and arguments. You go to these meetings, you read the journals, and you can see it on the journals pages: obesity surgery journal, surgical endoscopy, surgery of obesity and related disease. These are the biggest journals in the field. There are sleep studies that's supporting very good outcome after sleep. There are sleep studies that's supporting very bad outcome. There are studies with Roux-en-Y gastric bypass. There are studies against Roux-en-Y gastric bypass. There are studies which is supporting MGB. All MGB studies are producing the procedure as the best one. Why? Because all people who are reporting MGB are MGB surgeons. Roux-en-Y surgeon cannot criticize MGB, cannot present data against MGB because they are not doing the procedure. As simple as such. What they are doing, Roux-en-Y surgeons, they are criticizing the procedure. They try to present the MGB as not a good operation. And that's not right and not correct, because the bile reflux and cancer is just